Good morning, ladies and gentlemen. I would like to welcome you to Vienna. It was exactly 50 years ago when Aminorex was introduced. I hope you have nice 2 days here in Vienna. Thank you very much.
We are in the old Billroth house that's over 100 years old. It was opened in 1838 as the Chamber of Physicians. The main task was to regulate hygiene at the time, to fight infection. That's my introduction. Thank you.
This first session was extremely important too, because it emphasized how difficult it can be to identify a signal of a rare disease in a mass of information. So today was really important because we started with one of the most important studies ever in the field of pulmonary hypertension. It is called the DIPH study. It is a study which identified that appetite suppressant, and most precisely fenfluramines, were triggering pulmonary hypertension. And the senior author of this study, Professor Bernard Bégaud from the University of Bordeaux, was the first presenter, and he did a great job in presenting all the difficulties and the quality of the results. Then we had two other speakers who discussed more pharmacovigilance. One young clinical pharmacologist from the South Paris University, Dr. Marie-Camille Chaumet, she presented how we organize pharmacovigilance in the network of pulmonary hypertension, and she presented some cases of drug-induced pulmonary hypertension described in the network. She also showed negative results, showing that it's not always a positive result, but when you are looking for pharmacovigilance signals, you may have positive and negative results. Last but not least, we had a great presentation by Professor Herkner from the University of Vienna, but also from the European Medical Agency, and he showed how the regulation of pharmacovigilance is made in Europe and how complex but organized is a regulatory agency working on signals of pharmacovigilance.
We heard first about from Professor Kneussl regarding the history, basically, of the discovery of the Aminorex epidemic, how it evolved and what the clinical characteristics of it are. He pointed out that it's very similar in most ways to idiopathic pulmonary arterial hypertension, except, as some people noted, the survival tends to be much better. So it gave us a perspective, a historical perspective on the disease, and really is a foundation I think we need to have going forward. If you don't understand history, you're doomed to repeat it. I think in this case we think we understand a bit about it, but we've repeated it anyway. And that was the topic of Dr. Saval's talk, which was sort of took us through fenfluramine, which was responsible for the epidemic of pulmonary hypertension and, as he pointed out, valvular heart disease in the 1990s, on to similar findings with benfluorex and what the chemical structural commonalities are of those drugs, which might lead us to logically expect that they would have similar effects and adverse effects, which they do. Dr. Volkel spoke in a hypothetical fashion, I would say. He advanced hypotheses that toxic drugs have an effect on the enzyme system of the liver and the body, and can produce a milieu internally which then impacts endothelial cells and other cells that can be destructive or cause vascular disease and pulmonary hypertension, and certainly had, as Dr. Volkel always had, some insights and provocative ideas that can guide future research in a direction that may be productive and not simply an advance of what's going on now, but a paradigm shift approach.
Peter Dorfmüller spoke about the vascular pathology and highlighted that there are arterial and venous changes, and he also highlighted that plexiform lesions are the hallmark of this type of pulmonary hypertension that is precapillary. In the second part of the session, Harm Bogart summarized all the evidence on potassium channels, their function, and how they play a role in anorexigen-induced pulmonary hypertension. There's vast literature from Minneapolis illustrating that dexfenfluramine is depolarizing the membrane, and some discussion went on the type of potassium channels and their localization on organs and how that impacts the resting potential and the action potentials that are actually not present in smooth muscle cells. The third presentation was on serotonin, given by Mandy McLean from Glasgow. Taken together, this presentation illustrated the role of serotonin, both on pulmonary vascular endothelial cells, smooth muscle cells, and on platelets, and the role of a cytochrome, CYP1B1, that is involved in the action of serotonin, which is also responsive to anorexigen exposure.
Yeah, in my opinion, the news, interesting news, was that there is perhaps another epidemic worldwide with methamphetamine that has not been recognized before. We, in the pulmonary hypertension field, are clear that there are drug-induced forms, and we all like to be vigilant and observe how the disease is developing, because it still is developing and changing the phenotype, over time. And the methamphetamine story is probably going to be an important one in the future. What will be necessary is that we are spreading the word and educating physicians in different countries that this is a possibility to get the disease. And at the end, Dr. Sarmanian was talking about Ritalin. And as you may know, Ritalin is used in the United States for attention deficit disorder to treat children. And he already has numbers on small numbers of patients being identified as having developed pulmonary hypertension through Ritalin use. This is potentially a ticking time bomb. So pulmonary hypertension being an orphan disease, its association with drugs that people either have to take because they are sick, we'll talk about that tomorrow more, or that they are taking because of convenience or of indications that are not particularly strong, is worrisome. And what that means is that drug-induced pulmonary hypertension is not going to go away.
So this was a highly interesting and exciting session about the newer drugs which can cause pulmonary hypertension. We heard about the toxic oil syndrome in the 80s in Spain, which affected quite a lot of people. 300 people died, and obviously this was a very strong insult to the whole vasculature. We heard about a new topic, interferons, which seem to be have the potential to really induce pulmonary hypertension in quite a number of patients, and that is interesting for the drugs against hepatitis C and multiple sclerosis, for example. So it's important for many patients. We heard about the dasatinib-induced pulmonary hypertension. So these are drugs against chronic myeloid leukemia for the second-line therapy. And in the next talk, we heard how the mechanism of this might be, about the C-SARC, which is a very important tyrosine kinase, which helps the pulmonary vessels to maintain their function. And if it's stopped by means of dasatinib, this may cause pulmonary hypertension. And in the last talk, we heard about delta-like ligand 4 as a new treatment for cancer, but with a very high risk for pulmonary hypertension. When I calculated correctly, 11 out of 100 patients developed pulmonary hypertension who were treated with such inhibitors. And there's a very, very complex background pathophysiology behind this. And this is important in terms of drug toxicity on the one hand, but also in terms of new development for drugs for pulmonary hypertension. So it was a really exciting session.
Our drug and toxin-induced pulmonary hypertension meeting in Vienna, June 11 to 13, and it's the last day today, was focused on the memory of the Aminorex tragedy 50 years ago. And the date that we are celebrating and thinking of is the date of the approval of Kneussl. We have learned tremendously from this epidemic, although it was a tragedy for sure. And the Congress highlights the different aspects of anorexogen, but also of methamphetamine and chemotherapeutic drug-induced pulmonary vascular disease. And we are not only talking about pulmonary arterial hypertension, but we've recently learned that there's also pulmonary veno-occlusive disease as a consequence of drugs, toxins, and different agents such as exemplified by the toxic oil syndrome in the early 90s in Spain. I think it was a very successful meeting for a small group of highly focused scientists and clinicians.